Welcome to Verified RX, your prescription for success. Brought to you by the Weant Center for Pharmacy Practice Excellence.
Human rabies cases are fortunately rare in the U.S. Access to pre- and post-exposure prophylaxis and domestic animal vaccination programs drive this public health success. This comes at a financial and human resources cost, and here to share their perspectives are Dr. Kyle Weant, clinical assistant professor and an emergency medicine clinical pharmacy specialist at the University of South Carolina College of Pharmacy, and my Weant colleague, Dr. Philippe Mentler, senior consulting director. I'm Gretchen Brummel, your program host. Welcome to the podcast, Kyle, and welcome back, Phil.
Thank you.
Kyle, our listeners know Phil very well, so please tell me about your background and your practice site.
And I've been working in emergency medicine area for, a long time now. We won't quantify that exactly, but a couple of decades. My current practice site is a level 1 trauma center, academic medical center in Columbia, South Carolina. Prior to that, I've worked at multiple other academic trauma centers in the nation and love emergency medicine. That's what I do. I actually love the topic of rabies, so I'm happy to be here.
Tell me about rabies as a disease.
It's an awful disease. It's actually an encephalitis. Mammals either come in fit stage or they come in a paralytic state. We talk about hydrophobia, and that doesn't necessarily mean that somebody sees a puddle of water and they freak out. You could actually see YouTube videos if you're really interested, but give somebody who has active virus infection and you have them try to swallow water and they have this intense reaction as they try to drink this water where they're almost gasping for air. So they have this hydrophobia, aerophobia, very similarly to that, to the point that within onset of symptoms, 7 days before death, and there's really not much to do. There are roughly a dozen case reports of survival from this virus.
Those survivals are not high quality outcomes in terms of neurologic status following a rabies infection.
I'm really excited to have you both on the podcast today. Frame this out for me. How big of an issue is rabies exposure?
Rabies exposure, it's not so much that there's a large amount of rabies exposure, particularly in the United States. It's that if you have the exposure and you develop the disease, you have effectively a 100% chance of mortality. That's what makes it a big deal. If you look at the CDC in 2022, there were 5 cases, and actually 3 of those happened in a short period of time relative to years prior, which was 0 cases. And they made a big deal about that. Just 5 cases. And it was pretty important that they got the word out again, that we need to be diligent about pre-exposure prophylaxis and whatnot. It's less about the exposure and more about the really bad outcome if we do not treat it or prevent it.
It gets at the heart that this is such a unique thing. Give me another infectious disease where we have 100% almost guaranteed mortality. If you get it, it's terrible. And then when we approach it in terms of how we're responding in terms of post-exposure prophylaxis, we're going to overcompensate in a way, but it's understandable. And so we can't make it analogous to some other presentation that we have. And that's why it's a huge cost investment that we have, both in terms of animal control as well as post-exposure prophylaxis, but it's warranted. And so we do have to keep it separate in terms of the context within which we talk about because it's very unique.
Low volume, high risk, is that the term we use?
Astronomical risk.
No room for error here. How is public awareness of the issue?
In general, people are scared of it in terms of public awareness. Do they fully understand it? No. When you're talking to people, what do you think of? Oh, Cujo, the movie or something like that. That's their picture of rabies. When I'm teaching students and stuff, when I ask them, okay, well, what's rabies like? Oh, you're foaming at the mouth. Like, no, you don't have humans running around foaming at the mouth, biting each other. This is not a zombie apocalypse. But that's the perspective. We can do a whole lot more in terms of educating individuals. And I've even had patients come in. I had one mom, her children were found in a room with a bat. And so she brought them into the peds ED to get them post-exposure prophylaxis. While she was there, she communicated with the attending physician that, hey, I've been bitten before. And so they sent her to the adult ED and we're talking, I was like, why didn't you come in? Her wound had already healed. And it was just not a full understanding of it. When you have children, you take a different approach to things. You're more cautious. With yourself, there wasn't that. There's a lot of opportunity there in terms of public health education for the general public.
To add to that, I like to think about when I was a kid and I knew that if I got bit, I was about to get 20 shots in my stomach and it was going to be this awful situation. And so I wonder if there's this perception in the public that if they were exposed, that they would have a number of shots, it would be very uncomfortable. And so there might be a component of that fear takes in. The luxury is in the States, we are so good at vaccinating our animals, our pets, that the risk is exceedingly small.
Yeah, I've had patients come in, they definitively had an exposure to an animal that was at risk, and they were so scared. I've literally had to talk them down off the ledge. Just let us give you these injections. I know it's going to be painful, but it'll be okay. Far better than the alternative.
It's really interesting to hear about the fear of our historic or legacy protocols as being perhaps a barrier to entry into appropriate therapy. So what are our options right now for post-exposure prophylaxis?
They've been pretty consistent for quite some time now for post-exposure prophylaxis. Let's say it's your first time being exposed or potentially exposed. We start off with an immune globulin to give you a passive immunity, and then follow that up with vaccination over a particular series.
Is that specific to rabies, the immune globulin?
Yes, it's rabies immune globulin.
One of the big progressions that we've made, it's going to sound silly because it's so ridiculous, is concentrating that immunoglobulin. It used to be 150 units per ml, and so we're looking at 6 or 7 shots in some patients. Having a product now that's doubly concentrated at 300 international units per ml has been a game changer for us in terms of actual administration of this.
What I appreciate about 300 in practice was, let's say you get bit, the immune globulin should be administered around the site of the wound. And that's because the way the virus works is it initially replicates within that muscle site before it actually goes centrally. You want to inject as much of that rabies immune globulin as you can in that area. At 150 units per ml, based on your weight, because it's dosed based on weight, that's a lot of volume that you might not be able to fit. And the goal is to put as much volume as possible. By double concentrating it now, I have a lot more leeway to put a lot more of that drug in and around that site.
Yeah, and sometimes it's going to be in sensitive areas. You can have children that get bitten in the face by a dog or an animal. I've even had patients that stepped on a dead bat and have marks in their toe. And you think about, I'm going to inject in your toe. I mean, it's just so painful. So anything that we can do to limit those injections is really advantageous.
So you aren't into inducing compartment syndrome.
It's not my favorite pastime.
And that is a risk.
We alluded to cost a little bit in the intro, and I know some of our members have taken a dose rounding approach to rabies immune globulin. What are your thoughts there?
It's a really interesting concept. We have a lot of area where we can grow. I don't think we're practicing optimally right now. I don't know that we have the data to fully support what that eventual answer is. We have a situation where the World Health Organization is going to recommend that you inject around the site as much as possible, and then that's it. Whereas when you look at CDC recommendations here in the US, you're supposed to inject around the site in terms of the immunoglobulin, and then inject at a distant site the remainder of the dose. It's been shown that one of the most important things is injection around that site of the immunoglobulin in terms of neutralization of the virus. Potentially, could we get away with a rounded dose, maybe a lower dose? Absolutely. That being said, though, when you're looking at what the World Health Organization is looking at, the global problem that we have, and largely that's being driven by dogs, we have a larger bite volume, whereas here in the United States, that's not our primary issue. We're looking at somewhere around 80%, I think it is bad exposures leading to this. And so we're talking about maybe no bite, maybe a bite that can't be identified by the patient, or a very small territory there. Right now, what we do is a lot of it's just administered distally. So there's a lot of questions there. I don't know that we fully have the answer. I know some people have tried that dose rounding protocol, but it's tricky, especially when we consider the 100% potential mortality. Are we really ready to take that leap?
I recall reading a couple articles on this topic. One didn't really offer a reference as to why they suggested dose rounding to the nearest vial. The other one was actually looking at appropriate management of post-exposure prophylaxis. And they chose to say, as long as it's within 10%, it's fine, because there are other guidelines that show immune globulins and biologics can be dosed within 10%. I'm not sure I feel comfortable with saying, well, because I have these other biologic agents that I can dose within 10%, predominantly, I think, in the oncology space, and translate that again to rabies, which we know, again, has that very bad outcome if we actually have active infection. I'm not terribly convinced, not necessarily against either.
There are also the other things we mentioned, compartment syndrome. That's, of course, a concern on one end. The other aspect is the immunoglobulin. If you give too much, there's that theoretical concern that you will suppress your own antibody production after the vaccine. So there's that concern. And also in the studies that we've done in terms of actual practice implementation of this is people giving the remainder of that immunoglobulin at the same site as the vaccine, which we know is problematic in terms of suppressing your own antibody generation and development. And then even if it's not at the same site, it's still on the same side of the body. So how much is that impacting the vaccine efficacy and stuff? So I definitely think there's a lot of things surrounding the immunoglobulin administration, even beyond the dose rounding, that really needs to be assessed.
Is rabies immune globulin considered an essential medication that everyone should stock in their hospital pharmacy?
Yes, absolutely. Again, it's a low volume, but high risk negative outcome should absolutely be supplied.
These events leading up to using post-exposure prophylaxis happen at any time of the day, any day of the week. You may enter into the healthcare system through your PCP, urgent care, emergency room, may call public health. Who should be administering these drugs and who's ensuring follow-up of these patients?
The simplest who is your nurses and your ED, but there is the broader who. Should it be the emergency department versus your local health or state health department?
The way most municipalities are set up is, yes, you're going to the emergency department to get this. We need to separate out what's the bite, what's the exposure. If it's a bad exposure, you don't need to necessarily go to the emergency department. If you get bitten by a dog, you still need to come see us because we still need to give you antibiotics, which is another opportunity that's sometimes missed here. When we looked at it, I think 30% of the animal bites didn't get antibiotics on discharge, which they still need to receive. They're coming to the emergency department and we're giving that initial immunoglobulin. We do need to make sure that we have irrigation of the site if there is a wound. That also plays into it. Giving the immunoglobulin, giving the initial dose of the vaccine. Once that happens, even in the ED, then that's the real question. That's the subsequent who.
Speaking of which, Kyle, I believe I just saw a bat fly overhead. You might need a rabies vaccination.
Just going back to that incidental or concomitant care, ensuring tetanus vaccination as well with those types of, or up to date. In your experience, where are the potential pitfalls in patient management?
There's a number of pitfalls, and it's all around the administration. For instance, I just made a comment about the bat flying overhead and Kyle needing vaccination. A bat flying overhead is not an indication for vaccination. It's not like these drugs are absent of any adverse effects or adverse reactions. And so you have to be very prescriptive and diligent on who gets the vaccination.
Including financial immunoglobulin. The other thing I always worry about and what I would observe frequently is the dosing and administration of the products. Consistently, I would have to retrain individuals about administering the rabies immunoglobulin in and around the wound. And frequently, that wouldn't happen. It would always be IM injections and whatnot. Let's say it was because they might be treating a finger bite and they don't want to put any around that area. But they say, in all cases from here on in, I'm just going to give it intramuscularly. And that's based on the mechanism of the virus itself. The virus is hanging around that area and replicating around the wound area. That's where I want to try to get as much as possible immunoglobulin. I get it. When you have a bat, you don't see bite wounds. Sure, then you're going to give it wherever you can. But if you have active wounds, you want to be able to give it in and around that wound site.
I definitely concur. The administration, when we've looked at it, there's still a high number of people trying to give vaccinations in the gluteal region, which is definitively not recommended. And we know that the absorption, the antibody response is better in the deltoid with the vaccine. And then making sure that we're separating that immune globulin from the vaccine administration is really key. The other pitfalls of care are those subsequent doses of the vaccine. So we've given the first one. Now we need a couple other, 3 or 4, depending on the particular patient characteristics. Where do they go? That's one thing that's always been challenging. You can't, unfortunately, in most places, send them to the health department. You can't send them to the CVS or some community pharmacy to get their prescription filled for it. So they come back to the ED, which is a huge expenditure of resources and everything. We got other stuff that we need to do. Some places have tried setting it up with infusion clinics, infectious disease clinics to get those subsequent doses. Now, you're challenged there because ED, we provide care to everybody. You come through the door, we're going to treat you, regardless of your ability to pay or not. When you go out to clinic, it's a little bit different. People with insurance are more likely to go get those subsequent vaccines and complete that vaccination series, which is kind of intense because you're looking at the 0, 3, 7, 14. That's tough to keep up with. Most patients have trouble taking 1 pill a day. And then if they don't have insurance, can't go then they come back to the ED anyway. So that's a huge pitfall and a challenge that we have. We should have a overall public health investment in that care because if they do get rabies, it's an astronomical hospital cost when those patients come in with an exceedingly, unfortunately, low likelihood of a positive outcome. The cost to me is worth it for us to try to invest in a better care for all patients that have this.
So what should our frontline pharmacy staff know about post-exposure prophylaxis?
Depends on how we're describing and defining frontline. Some of the nuances that we've discussed here are really critical. We don't cover this in the average pharmacy school. Average resident may not have experience with it. And also, if you live up north, it's different than living in the south where there's more animals. So there's geographic distribution as well. The nuances of the administration, working with emergency medicine personnel to try to develop some workflows to how to do these, making sure that we're educating staff. Those are important things. For our distribution personnel in pharmacy, I think it's important to also recognize it's not a stat thing, but this holds up discharge. If we can front load some of these agents, whether the vaccine or immunoglobulin or both, in the automated dispensing cabinets in the emergency department, we can facilitate turning over these patients and getting them back to their normal lives and out of the emergency department and not consuming resources unnecessarily so we can focus on other things.
What I'd want my frontline pharmacists to know is how you're managing your automated dispensing machine with these products, then ensuring that they understand and educate the person administering the vaccine or immunoglobulin in particular. For instance, if I needed 6 mLs, I don't want to take 2 5 ml vials. I want to take a 5 ml vial and a 1 ml vial. That's a couple $1,000s difference right there. So from a savings perspective, the pharmacist should be aware of the adverse effects of the vaccine, especially if they're going to have any kind of counseling role in its local site, irritation, pain, induration, erythema, things of that nature. You might get a headache, general malaise, things like that they should be aware of. It's good for pharmacists to be aware of the potential drug interactions between the immunoglobulin and live attenuated vaccines. For instance, MMR, varicella. Make sure that you should not get these 2 vaccines for the next 4 months because they might be deemed ineffective. It's things like that. Your typical, what I would expect a pharmacist to do when it comes to understanding drug interactions, adverse effects of the drugs I'm giving.
You bring up a good point mentioning the vial size. If you do have pediatric population, you have that pediatric emergency department, you want to stock more over there of your smaller vial sizes potentially than your larger vial sizes that you'd have over in the adult realm. Technologically, while building the order sets and everything so that all that's auto-populated in terms of like the follow-up doses when they're being discharged from the emergency department, that it gives them good instructions so they know where to go. And then also so that automatically you can print that vaccination information sheet, which we should be giving all these patients that receive the rabies vaccine, and some of those nuances, such as don't get a live attenuated vaccine in the near future.
The pharmacist might be called on. We don't have this vaccine anymore. They switched the vaccine on us. Is it okay that I use this other vaccine? And the answer is yes. Of course, you always want to use the same vaccine if you can, but you could switch between the vaccines. They're both equally efficacious. Another question that might pop up the pharmacist should be aware of is Miss Johnson was supposed to come in at day 3 and now it's day 5. What do we need to do? Or they're supposed to come in at day 14 and now it's 2 months later. What do we do? And the answer is give them the vaccine. It's okay. You don't have to continue the series. What you may do, depending upon the stretch of time, is you may decide I need to do titers just to make sure that they have adequate response.
And that brings up a good point. The other aspect with the specificity of the recommendations, it's also understanding that the guidance does provide for some leeway in a day here, a day there. And so what we would commonly have is, okay, it said, come back in 3 days. 3 days is a Sunday. Okay, well, I guess I got to go to the ED. I can't go to my follow-up, the infusion clinic or ID clinic or whatever. No, you can. You can go on Monday. It's okay. You're not going to contract rabies just for that 1 24-hour period there.
Great advice from both of you. Thank you so much for joining us today to share your perspectives and expertise. I'm really glad that you could be here.
Thanks for having us.
Thank you very much.
And listeners, please join us for more Verified RX podcasts. Subscribe today, like us, and send us your comments. We'd love to hear from you. Verified RX is your prescription for success and is brought to you by the Weant Center for Pharmacy Practice Excellence. I'm Gretchen Brummel. Thanks for listening.